Hello guys, welcome to Gynae Wizard Snapshots. So today we'll be discussing our snapshot number 3. So let me speak about a patient which I saw in my antenatal OPD. So she was around 30-year, gravida 4, para 2, living 0 and abortion 1. And she had missed her period and UPT was done at home which was positive. And she was very anxious and she wanted to tell me about her previous pregnancies. She gives a history of one abortion, which was spontaneous, around 5 months of amenorrhea. And then she had two preterm births, one around 29 weeks and the other one around 28 weeks. Both babies were low birth weight and they were kept in NICU, but later, unfortunately, succumbed. So she had no living issues and presently very apprehensive, and she wanted to manage her present pregnancy well. So now I hope you people have got an idea about our case discussion of today. So we will be dealing with something called as cervical incompetence, or also called as cervical insufficiency. So what do we mean by this? It is the inability of the cervix to retain the pregnancy, and which is associated with painless dilatation of the cervix followed by expulsion of the products of conception. So usually it might be either in the mid trimester, that is around 5 to 6 months of amenorrhea, or it might also lead to a preterm birth. So this is mainly because of the structural or functional deficiency of the cervix, and there is absence of uterine contractions. So there are no signs and symptoms of labor as such. So it is always painless, and there is either a mid-trimester abortion or a preterm birth. So this cause of this, the failure of the cervix to retain the products, might be related to either the congenital cervical incompetence or any acquired causes which have led to cervical incompetence. So amongst congenital, we have the congenital uterine anomalies, especially the unicornuate and bicornuate uterus, which are associated with a cervical incompetence. So whenever the uterus does not have the strength to retain, it is also with the cervix which does not have the strength to retain the pregnancy, and it fails to do so, and it might abort or lead to a preterm labor. And then the second important congenital cause of cervical incompetence will be whenever there is collagen disorders like Marfan syndrome, Ehlers-Danlos syndrome. So all these are also associated with a cervical insufficiency. And when it comes to acquired causes, any cervical surgeries. So for example, any pre-malignant lesions of the cervix, which are either a cone biopsy or a large loop excision of a transformation zone, or sometimes LEDs, or sometimes cervical amputation because of the congenital elongation of cervix, or if any Fothergill's operation is done because of nulliparous prolapse. So all these where the cervical surgeries are done also lead to a cervical insufficiency. So these are said to be the acquired causes of cervical incompetence or insufficiency. So this is a standard diagnosis whenever there are repeated mid-trimester abortions or repeated preterm labors prior to 30 weeks, 34 weeks of gestation. So whenever this is there, you have to diagnose this and we have to manage appropriately. So the incidence of this cervical insufficiency is around 1 to 2% of total pregnancy losses, and 16 to 20% of the pregnancy losses which occur in the mid trimester or in the second trimester. And it is also associated with 10 to 15% of the habitual abortions which are taking place. So this is the brief incidence of cervical incompetence. So now when we get to know about the causes of this cervical incompetence, we have to also know about the diagnosis of this cervical incompetence or insufficiency. So many methods and many people came up with different methods which can either be done in the pre-pregnancy period or during the present pregnancy period. So we have many tests like a Shirodkar test, where we insert the 8-number Hegar's dilator, which can be easily inserted into the internal os. When we are trying to remove, there is no snap sound and it is easily being removed. So this is called as a Shirodkar test. or we can introduce a Foley's catheter and inflate it with 1 to 2 cc of saline, and then it can easily be removed from the internal os as there is no strength of the cervix to retain the Foley's. So that easily gets snapped off. Or when we can remove the Foley's, it is easily withdrawn with less than 600 grams of power. Or a Thielen-Day test where we can insert a olive-shaped sound inside the cervix without any resistance. So all these are the pre-pregnancy criteria for diagnosis of cervical incompetence. But all these tests are obsolete now. So now we mainly rely upon one important investigation, that is a transvaginal sonography, which is done during pregnancy. So previously there were hysteroscopic or histographic HSG guided classifications like cervical competence index and different scores for a diagnosis of cervical insufficiency. But all these are not used anymore. So now we completely rely upon the transvaginal sonography for measuring the absolute cervical length. And any cervical length which is less than 25 mm is said to be short cervix. So now, so to understand the importance of measurement of cervical length, we have to know how to measure the cervical length. So there are certain criteria which have been described by the ISUOG guidelines, that is International Society of Ultrasound in Obstetrics and Gynecology, and they give us a checklist to be followed to measure the cervical length and cervical length assessment. So what is it? So firstly, they always tell that the transvaginal ultrasound with the a probe frequency of more than 5 megahertz to be used. So transvaginal sonography is always preferred to transabdominal sonography. So we always have to use a TVS probe. So that is why we have to ask the woman to void urine, because if you do a transabdominal ultrasound with the amount of urine in the bladder, the change of cervix length will occur, because if there is a full bladder, there is elongation of the cervical length, which might result in false negative criteria. Or sometimes if there is the collapsed bladder, that time the cervical length might be looking small. So that is why transabdominal ultrasound is no more used and transvaginal sonography is considered as a gold standard. So how do we measure? So firstly, we use a transvaginal probe, which they have shown in this diagram, and then we have to just keep it at the level of the anterior fornix, and we should not apply too much pressure, because when you apply too much pressure also, there is alteration in the cervical length. And then we have to visualize the internal os, external os and the endocervical canal. So the internal os should be identified, the external os should be identified, and the entire endocervical length and the endocervical mucosa should be identified. So why these three are very important? Because sometimes we might falsely be identifying the lower uterine segments, segmental contractions, and we might include it in the cervical length assessment. So we might get a increased cervical length, but that is not correct. So that is why when we are measuring, we have to keep an eye on the endocervical mucosa, and this segmental contraction should not be used in the measurement of cervical length. And then the cervix should be occupying at least 75% of the screen, and we have to take at least 3 measurements, and the shortest of the 3 measurements should be considered as the cervical length for management purposes. So then again in ultrasound, so previously we used to tell that there was something called as a T-shaped cervix and something called as Y-shaped cervix and V-shaped cervix and U-shaped cervix. So it was remembered with a mnemonic called as trust your vaginal ultrasound. So based on this, they used to tell that there is some amount of funneling, some amount of opening of the internal os, and the prolapse of the membranes, and complete bulging of the membranes. But now all these criteria is not taken into consideration. So firstly, they used to tell what is the funnel depth, what is the funnel width, and what is the cervical length which is remaining, and they used to calculate the percent of the funneling, and then they used to talk about the shortening of the cervix. But now all these is obsolete. We only are worried about the cervical length which is present at the end. So this is the funneling of the cervix. So only this is the cervical length which we are interested in, and we no more take funneling as a criteria for our management purpose. So if there is funneling also, if the cervical length is more than 25 mm, we have to just watch and observe. And then, so this is considered as a very important take home point. So short cervix less than 25 mm, and do not watch for funneling. But one of the guideline mentions that the internal os diameter, if it is more than 15 mm in first trimester and more than 20 mm in second trimester, that also might have higher chances of mid-trimester abortion or preterm labor. So this is like one of the risk factor which has been measured with respect to the internal os diameter. But ultimately, we have to be measuring the cervical length, which is the functional cervical length which we are measuring, and based on this we have to manage our patients. So this is about the diagnosis of cervical incompetence or cervical insufficiency. Now coming to the management. So what do we do whenever we come across these types of history, and how do we manage our patients? So mainly there are two methods of management. So one where you do a serious surveillance of the cervical length, and the second one is where you go ahead and do a cervical encerclage. So this is mainly dependent upon our the patient's history and what the complaint she's come to us with. So when do we consider serial surveillance? So according to RCOG, that is GTG number 75 in the year 2022, so they've clearly mentioned that there are some risk category of women where we have to do a serial surveillance. So whom do we do a serial surveillance and we do not go ahead and do cervical encerclage is when there is high risk women. So what do you mean by high risk women? So if there is any previous history of preterm birth which is less than 34 weeks of gestation, or there is any mid trimester or T2 abortion in between 16, less than 16 weeks. So any of these situations between 16 to 34 weeks is said to be one of the high risk factor. And next risk is whenever there is PPROM, that is pre-labor pre-rupture pre-labor premature rupture of membranes less than 34 weeks of gestations. And next, whenever there is any associated uterine anomalies. And the next one is whenever there is cervical surgeries, especially trachelectomy, and if there is any intrauterine adhesions, and if there is any history of previous encerclage. So all these women are considered to have high risk, and we have to do a serial cervical assessment. So how do we do? Between 16 to 24 weeks, we have to do serial cervical assessment for every second weekly, and we have to see if there is the cervix is less than 25 mm or not. If the cervix is less than 25 mm, for these women we have to consider the cervical encerclage. So this is about the high risk category. Next, coming to the intermediate risk category. So in intermediate risk category, we have women with previous cervical, with previous cesarean section with full dilatation of cervix. If any leads of more than 1 centimeter is done, and if there is any history of cone biopsy. So for all these women, one scan should be done between 18 to 22 weeks to measure the cervical length. And if the cervix is less than 25 mm, even these women are the candidates of the cervical encerclage. So according to the GTG, they have clearly mentioned the high risk category and the intermediate risk category, and these women have to undergo a cervical encerclage if the serial cervical surveillance shows the cervical length to be less than 25 mm. Okay, so this is very important. So please keep it in mind. And one more important point I have to highlight is for every woman, as a part of her anomaly scan, three things should be done. One is the fetal anatomical survey, two is the cervical length assessment, and three is the placental location. So these three have to be taken into consideration. So it's primigravida. So for example, I will give you a case scenario. If there is a primigravida and she has any history, she doesn't have any previous history. So now she's come for a routine ultrasound during her 5th month, that is her anomaly scan. And in this anomaly scan, her cervical length is around 22 mm. So this is done, a TAS scan is done, and then it is reconfirmed by doing a TVS, and again her cervical length is around 22 mm. So in these women, so these are not candidates for cervical encerclage. So because they are primies, they do not have any previous history, there is no associated risk factors. So that is why these women have to be undergoing a serial surveillance, and along with that we can give vaginal progesterone. So this vaginal progesterone is prescribed to these women, and serial surveillance for every 2 weeks has to be done. And in this serial surveillance, every 2 weekly scan, if there is any diagnosis of cervical length less than 15 mm, so less than 15 mm, only then they will go ahead and do a emergency cerclage. That is, whenever the cervical length is less than 25, we will start with vaginal progesterone. Every second hourly, we will do cervical length monitoring. And then if you have found that the cervix is less than 15 mm, then you will put an encerclage, that is also called as a rescue or emergency encerclage, and you will also give vaginal progesterone as an adjuvant therapy. So this is about women who do not have any prior history of preterm births or prior history of mid-trimester abortions, and who do not have any other risk factors like high risk or intermediate risk factors. For these women, we consider a cervical assessment and a cervical surveillance. So this is very important for you to understand. Next, I will discuss each of these and you will understand completely about encerclage. Yeah. So now the indications of cervical encerclage. So ACOG has different indications, whereas RCOG or GTG has a different indication. So according to ACOG, so what are the indications of cervical encerclage? So there is something called as history indicated encerclage, physical examination followed by cervical encerclage, and ultrasound indicated cervical encerclage. So what is history indicated cervical encerclage? Woman with previous one or more mid-trimester abortions or preterm labor in the absence of uterine contractions or placental abruption. So these are women who are candidates for cervical encerclage. So this is called as history-based cervical encerclage. Whereas what is physical examination based? So whenever there is painless dilatation of the cervix, which has been seen in the second trimester, so that is called as physical examination indicated cervical encerclage. And the last one is USG indicated cervical encerclage, where women with prior preterm birth less than 34 weeks, and in these women, if the cervical length is less than 25 mm and which is less than 24 weeks of gestation, even these are candidates for cervical encerclage. So I will repeat, according to ACOG, history indicated cervical encerclage, that is, if the woman have one or more previous history of mid-trimester abortions or preterm labor in the absence of uterine contractions or abnormal abruptio placenta, and in these women we can do a cervical encerclage between 12 to 14 weeks after the NTNB scan is done and aneuploidy is ruled out. And physical examination indicated where there is painless dilatation of the cervix, there also a rescue or an emergency cerclage can be done. And women with previous history of preterm births and singleton pregnancies, if they have the cervical length less than 25 mm and their gestational age is less than 24 weeks, then even in these women we do a cervical encerclage. And also in women with previous history of cervical encerclage, so prior history of cerclage was done in her previous pregnancy, even in this pregnancy you will go ahead and do the cervical encerclage. So this is according to ACOG. But what does RCOG tell? RCOG is very clear about this. So they tell that if the history is more than or equal to 3, so at least 3, here it is 1, but here more than or equal to 3 mid-trimester abortions or preterm births, only then they go ahead and do an encerclage between 12 to 14 weeks of gestation immediately after the first trimester prenatal testing. So an ultrasound indicated is almost same, where if there is any previous history of preterm birth or mid-trimester abortion less than 34 weeks of gestation, and if the cervical length is less than 25 mm, then we go ahead and do a cervical encerclage. So these are the main indications according to the RCOG and ACOG. And next, coming to what are the contraindications of cervical. So the main contraindications are active preterm labor, whenever there is any acute infection like chorioamnionitis, whenever there is any imminent fetal compromise, and if there is any PPROM, and then there is any lethal fetal defect, or if the fetus has died in utero. So all these are the absolute contraindications for encerclage. So chorioamnionitis, PPROM, active preterm labor, and if there is any fetal compromise or lethal fetal defect, or if the fetal demise has occurred in utero. So IUFT is also one of the contraindication for encerclage. And always a cervical encerclage is done less than 28 weeks of gestation. And what is its role in multiple pregnancy? So whenever there is multiple pregnancy and if the cervical length is 25 mm, we do not do a cervical encerclage routinely. Why? Because this increases the risk of preterm labor. So in multiple pregnancy, there is no indication for doing the encerclage according to evidence. And even I told you about cervical surgery, we again divide them into high risk and intermediate risk, and do a cervical intermediate risk and do a cervical screening or surveillance rather than doing a cervical encerclage. Even when there is cervical trauma also, we do not do. And also as a routine practice, even in uterine anomalies, we do not do a cervical encerclage. But in obese women with BMI more than 35 kg per meter square, as there is higher chance of preterm labor, cervical encerclage might be beneficial. So they do not absolutely indicate, but it might be beneficial. Next, what are the types of cervical encerclage? So this diagram shows that there are two types of cervical encerclage, so which are vaginal and abdominal methods. And this can either be done during the preconceptional period or during the pregnancy period. So the abdominal can be either done in preconceptional period or during pregnancy, but vaginal are usually done during the pregnancy period. So what are the different used? So this, please pay attention. So what are the different techniques which we are interested in? So there were many techniques which were being done. So there was lash and lash, man technique, there was Benson Durfee, there was worm stitch, and there was something called as Shirodkars, modified Shirodkars, McDonald's, and laparoscopic. So there were some more than 20 different cervical encerclage procedures were practiced. But presently, we follow only 3 important types. So which I have described in this diagram. So the transabdominal cerclage is very high, and the transvaginal cerclage little high is the Shirodkar cerclage, and slightly low is the McDonald cerclage. So what is McDonald cerclage? It's the most simplest type So what do? We take the bites in and around the substance of the cervix. So we take it from the 2 o'clock position, then 5 o'clock position, then 7 o'clock position, and then 10 o'clock position, and we tie the knot, and we do not open any of the cervicovaginal mucosa. So it is tied as high as possible, and the non-absorbable polypropylene suture is used. So this is a McDonald's encerclage, and whereas the Shirodkar's encerclage, so there are two types. One is Shirodkar and one more is modified Shirodkar. In Shirodkar, we hold the cervix with the atraumatic Alice forceps. We put a incision on the cervicovaginal junction and extend it posteriorly, and then we tie a Merceline tape. So before fascia lata was used, but now they use a Merceline tape around the cervix, and it is tied anteriorly, and then the mucosa is closed. So this is how they used to just tie a tape around the cervix. So that was Shirodkar's. But what is modified Shirodkar's? We do not open the posterior mucosa. We just open the anterior vesicovaginal mucosa. We push the bladder, and then as high as possible, we take a stitch with the Merceline tape with the needles on both the sides. So one stitch is taken uh, from the 11 o'clock to 2 o'clock position, and then the 2 o'clock to 5 o'clock position, and the opposite needle is taken from the 11 o'clock to around 7 o'clock position, and the knot is tied posteriorly, and then the mucosa which has been reflected has been brought back, and it is closed with absorbable sutures. Usually we use Vicryl, that is polyglactin number 20. So this is a modified Shirodkar's technique. So the knot will not be irritating the bladder. So that is why it is tied posteriorly. And as it is taken through the substance of the cervix, the strength of this cerclage is very high. So when it comes to transvaginal cerclages, the modified Shirodkar method is mostly preferred, and it has a higher success rate when compared to a McDonald's encerclage. And if we are having certain indications of a transabdominal cerclage, so if there is any previous history of vaginal surgeries like trachelectomy, if there is any anatomical distortion of the cervix, or if there is any previous failed transvaginal cerclages, so these are the three very important indications for transabdominal encerclage. So transabdominal can either be done laparoscopically or laparotomy. So the laparotomy, usually Benson and Durfee, where they used to do a laparotomy, open the vesicovaginal fascia, push the bladder down, and they used to take at the level of the isthmus, they used to tie the Merceline tape posteriorly. So that was laparotomy. But now we have laparoscopy, and laparoscopy has been used to replace all the surgeries which are done laparotomy by open method. So in laparoscopy also, a window is created between the ascending uterine artery and the descending uterine artery and the isthmus, and at the level of the isthmus, the Merceline tape is tied, and it is tied posteriorly. But the only disadvantage of transabdominal cerclage is we have to do a cesarean section, because we cannot do a vaginal delivery. And this cesarean section can be done, and the cerclage can be kept in place during the interval of pregnancies. You need not remove it. But if there is any miscarriage, especially after 18 weeks of gestation, or if there is any intrauterine fetal demise, that time you might have to remove the cerclage. So whenever you have done a transabdominal method, and if there is a miscarriage or an IUFT, obviously you have to either do a posterior colpotomy or you have to do a laparoscopy, remove the cerclage, and then you can do a vaginal delivery, or you have to do a hysterotomy. So this is the very important disadvantage of a transabdominal cerclage. So I hope you understood the indications, the contraindications, and the role in different case scenarios, the type of transvaginal and transabdominal methods, and what do we do whenever there is delayed miscarriage, especially more than 18 weeks, and an intrauterine fetal demise after 18 weeks of gestation. Now, what have to be the prerequisites or the pre-op checklist? So, a detailed consent, we have to explain about the procedure, the need for the procedure, the type of procedure we are doing, and we have to tell them about the indication, contraindication, any other complications like bleeding, infection, sometimes PPROM can occur, sometimes onset of labor can occur. So all these things and risks risks and benefits has to be clearly explained, and a returned informed consent should be taken from the woman. And we have to assess her based on her history, examination, the length of the cervix, and then only you have to go ahead by doing a cerclage. And there is no role of amnioreduction or amniocentesis, and we need not do anything because there is no role, and sometimes that might lead to PPROM. So now I have to talk about two different types of encerclages. So one is history based, where I told you we will do an encerclage as early as 12 to 14 weeks of gestation, whereas ultrasound or emergency or rescue encerclage whenever there is bulging membrane. So sometimes they might come with some heaviness, and you do a speculum, the cervix is dilated, effaced, and the membranes are bulging. So what will you do in such condition? So in the labor room, you have to explain the woman, and if it is more than 3 to 4 centimeter dilated, it is of no use, and sometimes there is higher chance of failure. But if not, if it is less than 3 centimeter, and if you are able to hold some amount of cervix, it is always better to do a rescue encerclage, especially if it is less than 28 weeks of gestation. At least this will prolong the pregnancy by about 34 days. So at least the maturity of the fetus will occur. So you have different methods. So you can put a head low position, or you can put a small Foley's, and you can inflate the bulb so that the membranes are drawn inside, or you can inflate the bladder with around 400 to 500 ml of saline and clamp it, so that once the bladder is full, it will pull back the membranes, and then you can shift the woman to the OT, and either by regional anesthesia or general anesthesia or IV sedation, you can do the procedure. So the anesthesia, the discretion is entirely based on the surgery and anesthetist team. There is no definitive indication of this type of anesthesia should be used, but you have to be very gentle while taking your bites. So sometimes you might not be able to do a McDonald's or Shirodkar. In such cases, you can do something called as a worm stitch. So what is the worm stitch? It is rescue cerclage, where if this is the cervix, the knot is passed from 12 o'clock to 6 o'clock and back to 12 o'clock, and then 3 o'clock to 3 o'clock to 9 o'clock and back to 3 o'clock, and they are tied, and at least 1 centimeter gap is there between the two sutures. So they are tight so that you are almost occluding the cervical canal. So this is mainly to prevent the dislodgement of the mucus plug and to prevent the mid-trimester abortion or preterm labor. So this is something called as a worm stitch, but the chances of failure is high. So this is about the history indicated and ultrasound and emergency cerclage, and there is something called as a prophylactic encerclage, where it is usually done before 2 weeks of the previous mid-trimester abortion or preterm labor, if it is less than 28 weeks of gestation. So history indicated, examination indicated, ultrasound indicated, or prophylactic encerclage. So all these terminologies you have to remember. And what is the role of adjuvant management? So there is no role of bed rest, there is no role of tocolytics. Antibiotics might be considered if it is surgeon's discretion, and there is no role of any other pessaries or Arabian pessaries, all this. But the only thing which has role is vaginal progesterone. So along with the cervical encerclage, you can also supplement vaginal progesterone, because this might have some role, but there is no role of any injectable progesterone. So this is about the adjuvant management along with the cervical encerclage. And you have to explain the post-procedure follow-up. There is no need of routine ultrasound monitoring after encerclage, but you have to explain the woman if she has any bleeding, foul-smelling infection, fever, tenderness or pain. All this she has to immediately review. Otherwise, you can call her for a routine antenatal checkups. And post-procedure sexual abstinence is also not very much indicated, but it is also recommended on a case-to-case basis. And next, very important, is the removal of the encerclage. So when do you want to remove? So whenever you are considering vaginal delivery, it is ideal to remove between 36 to 37 weeks of gestation. But if you are considering a pre-labor cesarean section, then you can retain the cerclage till you do a cesarean section, and you can remove it during the time of cesarean section. But if you're doing if it is a trans-abdominal cerclage, you need not even remove it because it might be there persistently in the intervals of the pregnancies. So again, I will repeat, remove the cerclage if you're planning for a vaginal delivery between 36 to 37 weeks, and if you're planning for a pre-labor cesarean section, you can remove it at the time of cesarean section, or if it's a trans-abdominal cerclage, you need not remove also. So that is about the removal. But if she goes into preterm labor, or if she has any PPROM, then what you have to do? So what is the fate of cerclage whenever there is preterm labor? So if she has any onset of uterine contractions, kindly remove it, because sometimes if there is cervical dilatation and if there is a cerclage, sometimes there is trauma. So there is tearing, the cervical lacerations which might profuse bleed. There might the profuse bleeding might be there. So they might profusely bleed. So that is why we have to consider immediate removal once she sets into labor. And what about PPROM? So PPROM, in such cases, you have to either consider waiting for removal, or you can do a immediate removal. So in case of PPROM, that too, especially when it is less than 34 weeks of gestation, you will have three scenarios. So if you are planning for a in utero transfer, so you are planning to send her to a good hospital with a level 3 NICU setup. So in that cases, you can delay the removal for at least 48 hours if there is no signs of labor or chorioamnionitis. So if there is no signs of chorioamnionitis or labor, you can delay for about 48 hours and you can send the mother to a facility where the level 3 NICU is available for the well-being of the fetus. So for this in utero transfer, we can delay for the removal for about 48 hours. But if she's already gone into preterm labor, we have to immediately remove the encerclage, and there is no role to retain the cerclage after 48 hours. So 48 hours you have to never wait. So before 48 hours only, shift the mother, give a course of natal corticosteroids, and after 48 hours you just remove the encerclage. There is increased chance of both maternal and fetal morbidity and sepsis with delayed removal of cerclage. So that is why we do not wait after 48 hours. But if it is less than 24 weeks or more than 34 weeks, you do a immediate removal of the cerclage if there is PPROM. Why? Because less than 24, the baby is not viable, and if it is more than 34 weeks, you can deliver the baby because it's almost mature. So that is why in between this less than 24 and more than 34, you need not wait and you can immediately remove. But if it is less than 34 weeks and more than 24 weeks, we can delay for 48 hours. But there should be no signs of labor or chorioamnionitis. So this is a very important take-home message when it comes to PPROM with cervical encerclage. So I would like to mention that you have to understand the importance and the indications of cervical encerclage. It's not that you go ahead and do cerclage for everyone, because it is not, it has some of the risks also. So there is 1 to 7% development of chorioamnionitis. Sometimes there might be PPROM. So all these bleeding risk might be there. So all these risks are there. So always your benefit should overweigh the risks, and then only you have to understand the proper indication and then do a cervical encerclage. And it is mainly the surgeon's expertise to do which method, but the evidence as such does not differentiate between any method. So it tells that almost all the methods are useful only. So this is about cervical encerclage. So hope you all understood, and you can read the GTG number 75 for further understanding. Thank you. Have a nice day.